Hello, I'm Michael Goldberg, scholar in residence at the Schwartz Center for Compassionate Healthcare, and I welcome you all to our Compassion in Action conference. Today, we're going to have a conversation. It has a title called The Missing Link, Compassion in and Through Caregiving. And the conversation will be between Laura Crooks, who is Chief Executive Officer of Yakima Children's Village, a multi-specialty clinic providing some 30 services for children with special health care needs, and is also co-founder of Chad's Legacy Project, an organization committed to education, evaluation, and treatment of mental health illness. And conducting this interview with Laura will be Sophia Moras, who is medical director of the 3 East Girls Intensive and Step Down program at McLean's Hospital in Waltham, Massachusetts, and an instructor in psychiatry at Harvard Medical School, and a 2019 recipient of the Schwartz Center National Compassionate Caregiver of the Year Award. And so, without any further conversation from me, Sophia, Laura, it's yours.
Thank you so much, Michael. I'm so grateful to have this opportunity to have this conversation with Laura. And I would like to start off by, Laura, if you could just share with us a little bit more about Chad's Legacy Project and how that came about for you.
Yeah, thank you. Thanks everybody for being here today. Sophia and I have had a couple of times to talk before this webinar, and just really excited to share our conversation together with all of you. So Chad's Legacy Project is a nonprofit, and it's really dedicated to 3 different components for those people living with mental illness, their families and caregivers, and that is around reducing or getting rid of stigma associated with mental illness, access to care, and then finding effective treatments and maybe even cures someday for some of the mental illnesses. How it came about, and some of you may have heard me speak at the Story Slam at the Schwartz Center last year in the evening, but I'll tell you really quickly my story and our story, mine and Chad's and my husband Todd. So Chad is our oldest of 4 kids, and he would be 26 right now. Chad was really smart, really artistic. The picture that you see behind my head is a self-drawing that he did that hangs in our dining room. And he went away to college for mechanical engineering, and in his first year came home after struggling and let us know that he had been hearing voices and was beginning to see creatures following him, and it was scary for him. At one point he did in the spring have a pretty significant psychotic break where he became suicidal and was going to jump off the bridge around the corner from our house. We wrapped him up and took him to the hospital. I'll tell you a little bit more about that story as we go along, about what happened in between there. Came home for 4 days and went back into the hospital again, and then came out to outpatient. And from that time, which was in April of 2015 to January of 2016, Chad was in outpatient care for his mental illness. And in January of 2016, Chad, in the middle of the night, went around the corner from our house after the voices told him that he shouldn't be here anymore. And he jumped off the bridge around the corner from our house and died by suicide. That was horrible enough in itself, and we tried to find, how we could help other people so that other people don't have to live through this. But the other part to my story is what happened to me at work. And so at the time I was a director at a local children's hospital. And when I came back to work, there was a real challenge in how people interacted with me and how I felt being at work, in that the compassion, we have compassion for our patients and families, and it wasn't the same for somebody who'd been through this horrible tragedy. I think part of it is people don't know how to talk about when something horrible like this happens, how to talk to that person. Sometimes people feel like they have to have the perfect words and they don't. And sometimes in healthcare, we really all function at a very high level, which we have to in order to do this kind of work. But then when you can't function at that high level because of profound grief or pain or other things that are happening, we don't know how to handle that. And we don't know how to handle it in each other. And that certainly became present for me. So Todd and I, after losing Chad, really stepped into this space. We spoke about what happened with Chad and with our family. We talked very openly about the fact that, when he first came to us with the fact that he was hearing voices, that we didn't know what to do. Psychiatry is not my specialty. And so, we made mistakes along the way, and that we're here not because of what we knew, but because of what we didn't know. And so we started Chad's Legacy Project really to try and address those issues that we heard from so many people. Because once you start to tell your story, other people start to tell their story as well.
Absolutely. Laura, I'm so grateful for your willingness to share this. And especially thinking about both sides that you had to weigh. On the one hand, being Chad's mother and, taking care of him, but also being his advocate and having to navigate a pretty difficult system. And what I'm wondering is, what did you learn along the way? How much were you able to do because of that experience that you had in navigating the system? And it sounds like you realized not a lot of people had those opportunities, right? Those options. What did you pick up along the way?
Yeah, so there's a few different things and a few different routes we could go down with that question, but just at a very high level, and then I'll tell you a story. At a high level, what we learned along the way, and what I learned along the way, is it's not good enough just to be frustrated with the system. And you can get caught in blame for a lot of different reasons and a lot of different pieces in this, but that doesn't really help anybody, and it doesn't change anything. And if you want to really make things better for other people and move from this place of profound grief, I needed to really create action. And Todd, my husband, and I talked a lot about that. It's hard, it's exhausting, it's painful, but it's really important, and that you can move into a place where you can create action to move people along. We'll talk about Chad sitting in the waiting room and our experience with the EMTs in a little bit, but the story that I want to tell about this particular part has to do with the medical director that I work with, and I think some people probably know this story. When I came back to work, the medical director that I worked very closely with, who is a very compassionate physician, has won the Family Choice Awards, works with children who have life-limiting illnesses, just a really incredible doctor. And after a couple of weeks of me being back at work, we had a meeting where she said to me that she felt like I was letting things fall through the cracks and that I was too sad and that people couldn't come to me. And what did I have to say about that? This compassionate doctor, that's what she said to me. And so I got up and I left her office. And then I really thought about that. And I thought about how, if we're really going to have compassion for each other and we're really going to live in this space and have compassion for patients and families, we have to figure out how to do it in healthcare with our peers and with our colleagues as well. And so that was one place where I really felt like I could take action in changing what the narrative is around you don't have to be perfect. We are humans caring for humans, and we have to figure out how to have compassion with each other. The other thing is really looking at the system. So it would have been really easy for us to blame the system for what happened to Chad, that he fell through the cracks in a lot of ways, that we had a lot of interactions that were way less than positive. But those were people who were really doing the best that they could. And if we take that perspective, then we can say, okay, they were doing the best they could. They're well-meaning people, but we've put them in systems and processes that don't enable them to really be compassionate towards people with mental illness. And so that's what I've sort of learned, is that you gotta take a deep breath. And when you want to really be reactionary, you gotta pause and say, okay, what's the why behind this? And what can we do to make things different? And if we can do that, and we can step into it with compassion for the people in front of us, then we can fix those problems and we can make it better.
Yeah, it definitely sounds like the difference between saying, what do you have to say for yourself versus what can I do to help you, right? Whether
Absolutely.
it's what you're describing at work, that instance, versus what we can do for each other's colleagues and what we can do for patients. I think as caregivers, we're much more prone to show that outwardly. And I think in giving compassion through caregiving, it has to be sort of inwardly shown. Can you tell me more about that blame part?
So when we lost Chad, we met with his caregivers, and we met with the head psychiatrist at the hospital and the social workers who took care of him, and the nurses and stuff. Yeah. And I think that initially people were like, oh, we don't want to meet with them, because I think that they felt like there was an obligation to meet with us, but that they were very cautious, because I'm sure that they hear a lot of very angry people, a lot of blaming, and we stepped into it very differently. We very much talked about, what happened with Chad, but then we talked about, we know that the systems were failing him, and were failing the caregivers who were trying to take care of him. And that we really wanted to be a part of the solution for how we could change that. So when Chad died in the state of Washington, Washington was ranked 47th in the nation for mental health care, 47th. And we're a pretty progressive state. And that was shocking. And so we started Chad's Legacy Project to say, we're going to be a top tier state. We're going to move from 47th to the top 5%. And we're slowly moving along. We're in the 30s someplace, I think now. But in having that, and having speaking really outwardly about that we're not blaming, we're really saying, okay, what happened and what do we need to fix to make this better so that it doesn't happen to other people? That sort of changed our ability to step into this with people who do this kind of work every day, like yourself. And really figure out, okay, there are things that we can put in place that might actually help. We can put things in place from the parent perspective, from the person who's living with mental illness perspective, and from the provider perspective, and that could change things.
Absolutely. And it sounds like partnering as opposed to sort of being on the opposite side, right? That you invited them to join you in this effort. Yeah.
And they jumped at that. So one of the examples, well, I'll give you two examples of that. So I worked at Seattle Children's Hospital, and I brought to Seattle Children's the idea of bringing youth mental health first aid to any family who wanted to take it. So for people who know about mental health first aid, it's talked about like CPR for mental health, right? It's how to interact with somebody who's in crisis. Even if you don't have any skills, you can get through this initial piece, make sure that they're safe till they can get help. And so I really wanted to bring youth mental health first aid to Seattle Children's Hospital, because I learned about that after we lost Chad. And I think that would have been a real game changer for us. Got grants, and Seattle Children's then began to offer youth mental health first aid to anybody in the community. Chad's Legacy Project, we raised money for grants so that people could take it for free, so we could remove all barriers They would not. And at first, when I brought it to them, they were a little reluctant to do this, to offer this class. And it was challenging, but then they embraced it because we really removed all the barriers. We said, we want to work with you on how to do this. And now they offer it on a regular basis. The other thing was talking with the psychiatry department where Chad got his care. And in partnership with the University of Washington, we started the Washington State Mental Health Summit. And that's where we bring providers, payers, government officials, families, advocates all together in one room to say, how are we going to focus innovations in the state of Washington to really move the needle in what's happening? And we offer that for people to attend for free. We get all kinds of people. We get policymakers, legislators, senators. We get the medical directors from some of the health insurance companies, because they want to focus efforts. And we said, if we can focus on a couple of things and do those really well, then we can bring in the next things and do those really well, rather than focusing on a whole lot of things and doing nothing well. And when we brought it to them, and with that sort of mindset, then, the people at the University of Washington were very much, yeah, we want to be a part of this, and we want to do this with you. And that's been a real game changer for our state as well, which is super exciting because everybody wants to do the right thing. And it's hard when you're, in the grind, in the challenge of just getting by day to day as well.
Absolutely. I think what's remarkable is your capacity to couple such a huge loss with action to figure out, how do I move from this place to making actual changes? And I was wondering about the stigma, because it's not just a doing and action taking, but there's also a shift in people's thinking, how they perceive mental ill patients, how they perceive the families of those patients, and how do they see themselves within that system. Can you say a little bit about your thoughts on the stigma and how you're using Chad's Legacy Project to address that?
Yeah, so I'm going to share the story about the EMT, because I think that's a piece of stigma that comes up. And I'll just say that when Chad was very first telling us about the voices and the creatures, he asked to speak to me privately in our bedroom so that the rest of our family couldn't hear. And we have 3 other kids. We're a very tight family. We talk about everything, and he didn't want people to know that stigma was ingrained in him, was ingrained in us. Because I thought, oh my gosh, I could have handled, it's going to sound really terrible, but I'm going to say it anyway. I could have handled Chad having a spinal cord injury. I didn't know what to do with a psychiatric disorder. Like, for me, I was like, oh, it was really devastating to me. But the story that I'll tell is, after Chad got out of the hospital and he was home for 4 days, he had a panic attack, and the voices were really bad, and he felt like his heart was going to explode. He was totally inconsolable. We didn't know what to do, and we had to call the EMTs to come and get him. And they came to our house, and when they were assessing him, and they were going to take him to the hospital. And the EMT, which I very clearly remember this moment, I will remember this for the rest of my life, which really drives me, because I'm sure this person was a great person, but in that moment, the stigma really showed up, right? It was, he said, is he on any medications? We said, we want to take him back to this hospital where he just got discharged, and he is on sertraline for depression and risperidol. And as soon as I said risperidol, that EMT rolled his eyes and said, oh, he's schizophrenic, like that. Number one, we had not been given a diagnosis of schizophrenia at that point. Number two, he said it as if it wasn't real for Chad, as if what was happening to him was not real for Chad, and as if it wasn't real for us. And it was very real. And that stigma of what is mental illness just showed up so prevalent in that moment. And I will remember that moment forever, not as a blaming of that EMT, but as a real moment in time indicator of how we look at mental illness, as if it's not real, and it is very real. And so, you know, stigma shows up in so many different ways, in the inability to ask for help sooner. I wish Chad would have said something sooner to us. I wish we would have noticed and asked him, in how he received care, in how we interacted with each other. One time I went to go see him in the hospital, and somebody from Seattle Children's gave me a ride to the University of Washington hospital where he was at. I didn't tell that director who gave me the ride to the hospital why I was going to see my son, because I didn't want to say he's in the psych unit. And now I speak very openly about that, because if I can't say that, how can I expect other people to? And if we can't say that as healthcare providers, how can we expect people to really access effective care and to seek care early? And if we don't talk about that as systems, how can we ever fix what enables people to fall through the cracks, or even prevents us from finding effective treatments and cures for the future? So things like this, talking about it, telling stories, making sure that they're not just blaming, but really around action, that's what's going to get rid of the stigma and enable people to get more effective early cures. And I would just say we are doing things in the schools through Chad's Legacy Project. My husband is involved in a project right now that's looking at effective curriculum in schools for mental illness and mental health and social emotional learning standards, enabling schools to just take curriculums and implement them in the schools, which is wonderful. And we just passed legislation this last spring that will put on the back of every student ID in middle school, high school, college, and universities a crisis number and a text line, so that when kids need help, they have access to help right in that moment. And I think doing those kinds of things, making it really normal, so it goes on, doesn't wait till you ask for help, it goes on every student ID, because everybody may need help once in a while, then that gets rid of the stigma too. So it has to start early, and it has to go all the way through the entire systems that touch people.
Absolutely. I was really struck by the story around the medication, as I said to you before, because there's so much in that moment. Everything from, there's so many different uses of the risperidone, right? And that stigma really sort of shuts out the curiosity. It doesn't allow for the possibility of there being other issues, right? And even if it were schizophrenia, then it's still shutting down the possibility of he's more than his diagnosis. There's so many other things around there that we're not accounting for. And it really stayed with me, Laura, because I'm also thinking from an educational perspective, even training, right? That even in sometimes medical education, there is a stigmatization of psychiatry. And we think about, there's a ripple effect that can happen in the community. So I'm really glad to hear about the educational piece, because I think that could shift some of the culture and the thinking around that. I wanted to hear more about, in terms of for your training, like what else you're doing outside of work to help with this.
What else am I doing outside? It's all blending together, right? Like, oh my gosh. So, so we, there's a lot of things that are happening. So, you know, I talked about the student ID. I talked about the curriculum in schools. We are really very much promoting mental health first aid, and actually we are one of the pilot centers for mental health first aid online now, so that it used to be just an 8-hour class in person, but now there's a 2-hour module that you do prior to the class, and then 6 hours in class, but that's virtual. And so that's advancing. In the mental health summit, we have initiatives right now where we have a advisory committee who looks at all the initiatives. So we do out a call for initiatives, and then people submit ideas. They have to be ideas that have been well fleshed, and they just need some help. So not just funding, but you need to bring people together in order to move your initiative forward to the next level. And we pick 6 to 8 initiatives. And on that advisory council are people like the head of the healthcare authority, the medical director for Blue Cross Blue Shield for psychiatry and mental health. There's the behavioral health specialists and psychiatrists, and there's family. And we pick the initiatives to be presented, and then we ask everybody to sign up for those initiatives. So one of them is around peer counseling and peer training, really advancing that. We are now looking at a family bridger position that's just about to go into effect, where we connect a family who is has somebody newly diagnosed with a mental illness with another family who's been through the system to help them navigate that mental health system, because it's really confusing and really hard. And so really pairing them up with someone who can really help them navigate that. We've advanced the peer bridger program, really connecting people with newly diagnosed with mental illness with somebody with lived experience, so that they have hope for the future. That's really, really important to us. And making sure that they're well connected. What else? I think there's a few other things. You know, we're hooking up, looking at peer bridger with the police and first responders. So when they go out and respond to somebody in a mental crisis, they actually have somebody who is trained and with lived experience to connect with that person who's in crisis and help de-escalate the situation from just a police response to actually a compassionate response to somebody with mental illness. And I think all of those things are really gonna be game changers for what happens for the future. But there's so much to do.
Absolutely. With the peer bridger, it sounds like a great way of making use of the expertise you've gained, right? Because if you think about it, my perspective in the system is as a psychiatrist, right? Your perspective is as an advocate and a parent. And there's a connection there, and they're not exactly the same. That you bring an expertise from having navigated it through that perspective that's so important, that could actually help the patients in a way that would be very difficult for another clinician to provide.
I think that there's I like to tell stories because I think that they're impactful for people. There's a story about Chad where he was in outpatient care, and he also had a job during that time. And he didn't tell his job, although they were very, very supportive of him missing so much. They knew he had some kind of a health issue, but I don't think he told him what it was. But he would have his outpatient appointments for his schizophrenia. And he would also have, he'd be scheduled to work, and he would want to go to his appointments, and either he wouldn't have money, so he couldn't pay for the parking, so he'd just skip his appointment because he couldn't park anywhere, and he didn't want to get a ticket or get his car towed. Or he would be scheduled for work, and he would be scheduled for his medical appointment, his psych appointment, and he didn't want to lose his job. And in his psych appointments, there was never really any push, I think, or urgency from his perspective. So he would go to work and he would miss his psych appointment. And then, nobody really helped him with navigating that. And with the challenge of, well, if you've got both, here's how you do that. He was just a kid, he was 19 years old trying to figure this out on his own. Or he would ask, mostly Todd, because Todd worked out of our house. So Todd would kind of help him when he knew about it. But most of the time, Chad was trying to figure it out his own. He was trying to be a 19-year-old boy with schizophrenia, with a mental illness. And just by definition of that diagnosis, it's really hard to keep yourself organized and to really problem solve and to think logically. That was just not something that was in his ability at that time. And we set him up to fail there because, he'd miss his appointments, and there was never any, oh, you missed your appointments, it's really important for you to make it, we're going to get you in as soon as possible. It was like, oh, well, you can wait till your next appointment. So for him, it was sort of laissez-faire, and he didn't know, really in the long term, what were those appointments going to do? Because a lot of it was, try this medication for 6 weeks and it doesn't work. Oh, we're going to bump it up a little bit. We'll try that for another 6 weeks. It didn't work. Oh, we're going to try you on a different medication now. That medication didn't work. Oh, we're going to put you back on the first one. For him, it was just sort of this trial and error stuff. And it was for us too. And there wasn't that, he wasn't eligible for a peer bridger, which is another story. He wasn't eligible for that. And so he was never connected with anyone who actually got through that kind of a frustrating system to be able to provide him hope that actually it does get better. And you can't expect remission from this. You can't expect a really highly functional life out of this. And he didn't find that.
Yeah. And I think it brings up the other piece here, and I talked about in terms of HIPAA, how there's, on the one hand, the system is helpful in maintaining privacy, and it kind of intersected at a really difficult time for Dad, because here he is legally an adult and, you know, through that developmental stage, but also dealing with a mental illness and navigating this really complicated system.
Yeah, so Chad signed all kinds of releases for us, and they would not talk to us, even with all the releases that he signed, even when he said it's okay to talk to my parents. It would still, there's this misperception about HIPAA, I think, sometimes, and especially in the world of mental illness and mental health, it's really, I think, challenging and navigating for people to navigate. And there's so much worry about litigation and all of those things that come into play. You know, one of the things that we're working on, in addition to all the other stuff that I talked about, is mental health advanced directives. And really having somebody be able to have a plan for, here's who I want to make decisions for me when I'm in crisis, or if I become psychotic and I can't make decisions for myself, here's who I want you to pull into the care. Here's what I want to have happen. And this is what I don't want to have happen. This is how I'd like to have medications. And this is how it's even things like, I don't want to have injections, but I'll take pills. I don't want to have restraints, and here's how to handle me without restraints. Those kinds of things, really, practical things that do come up when people become psychotic. But enabling people to do that while they're well and make that plan while they're well. But then you got to make it accessible to people. And then you got to say, you got to follow this, like advanced directives that we do for other kind of medical care. And I think that that's a challenge, but we'll get to that. The other piece of it is, how do we make it so that that stigma and that ability to really be compassionate in this space is hardwired in our medical systems. And, we create stigma and barriers for our providers when we ask people who are applying for their license or getting their license renewal. And as, physicians, I know in many states, they ask, have you had any, care for mental illness, or have you sought care, or are you on any medications for things like depression or anxiety? And if you answer yes to any of those things, then you're, potentially put on a provisional license. And those things should be okay for, you don't put somebody on a provisional license if they're taking insulin, I don't think, right? Or, blood pressure, low blood pressure medication or whatever, but they do that for mental health and mental, illness. And if it's not a serious mental illness, they shouldn't be setting people up for that stigma ahead of time. And how do we get rid of those sort of barriers, as well as a whole nother piece that we got to step into, because we'll never fix the system if we don't support the people who are in the system.
And it's such an opportunity too for, I think, as caregivers, to model the very behaviors we'd like to see our patients have, right? Whether it's following up on those appointments, making time for our mental health, and being able to sort of verbalize when those things are interfering with our professional lives. Like, as I was saying to you, Laura, in our training, we are rewarded for knowing, we're rewarded for being confident in the knowing. And I think entering a space where there is less knowing, there is less certainty, it's really difficult. And it's easy to fall back to the stigma of not knowing what to do when you're vulnerable. I don't think we do well when we're feeling vulnerable. And that's precisely, part of being compassionate towards ourselves is recognizing that vulnerability and recognizing it in others and bridging that gap with them.
Yeah, we talked about, if I could rule the world, right? Or at least rule the world of health, what I would like to see is this ability to really lean in with compassion and to be able to recognize when people have situations that they put in that could be stressful or challenging, when they're having challenges themselves, or when something is maybe just a little teeny off, like maybe something is happening at home and they haven't said anything to anyone. And about how we could practice health with each other like we practice it with our patients and families in those situations, where we could say to somebody, I know with that nurse, I know that you were just in that room and that family got a really bad diagnosis and that must be tough for you. You know what? I've got your call lights. Why don't you go get a cup of coffee and come back in a few minutes, take a few minutes to take care of yourself. Or to a physician or surgeon who maybe something doesn't go quite right in that OR and they got to talk to the family and they got the next surgery waiting, figuring out a way that we could say, okay, go talk to that family and we're gonna figure out your next case so that you can care for yourself, so that then you can care for the patients and families. Really saying, something, you seem like maybe you're having a tough day. I'm having a great day today. Can I take some of your patients for you? Or can I take this piece? Can I go to this meeting for you so you don't have to deal with it? Really leaning into those places where we can have those honest conversations where I could say, today is kind of an off day for me. And so if I'm distracted in this, just let me know. Or if you need something from me, you got to follow up with me because I'm not going to catch it myself. And being okay to be in that space in healthcare, because we do put ourselves at such high pressure to perform so highly all the time. And then we end up doing that with each other and can't recognize the vulnerability in being human. And how we do that is through compassion. It really is through compassion, having compassion for ourselves as much as for our patients. Absolutely. And having compassion for each other, knowing that we are humans.
Yeah, it goes back to what you were saying when you were asked, what do you have to say for yourself, right? Versus how can I help you? What do you need in that moment?
Yeah. It's hard. And, there were lots of times when we didn't lean in with compassion. I told you the story about Chad waiting in the waiting room. So when he was taken to the hospital by the EMTs, we told him to take him to this one hospital and they took him to another hospital. And we ended up at the first hospital because we thought that's where he was gonna show up. And in that moment, there was some compassion because we showed up and the triage nurse who was sitting there, Chad was not there. And we asked if he was there and she said, no, I don't have anybody by that name. And she said, nobody's been brought in. And I said, well, we got to figure out where they took him. And she said, I can't tell you anything. And so then I stepped into this HIPAA place, right? I put on my hat and said, okay, well, I'm on the trauma council for King County, and I know you can't tell me because he's a 19-year-old boy. But if there was a 19-year-old who was picked up from this address at this time and taken by the AMR to the hospital, where might have an AMR gone from this address at this time? And I said, and I happen to know that because I know what that data looks like, and I know you can pull that up on the database for the state. And she goes, okay, well, and she pulled it up and she said, well, if there happened to be a 19-year-old picked up at this address, they might have taken him to this hospital. And I said, thank you very much. And we left. So she had compassion with us, right? To know we were a desperate family just trying to figure this out. And we were trying to work within the system. So we went there, and this hospital that he was taken to is right by the freeway, by I-5, the biggest freeway that goes right through Seattle, right? And where this hospital is, there's a bridge and overpass that goes right over I-5. Now remember, Chad was hospitalized for being suicidal and wanting to jump off a bridge. in this huge waiting room was this 19-year-old kid sitting all alone, rocking back and forth in a chair with no one around him. And we sat down. They did give him a little blanket to put over the top of him, but there was nobody there. Nobody checked on. We sat there for a while with him. Nobody checked on us. Nobody came over and asked us, who are you, with him? Nothing. And Todd got up and went and talked to the admitting clerk who was there. And she just said, we'll get to him. Just wait. And we sat, and it was awful. And so I said, we got to do something, Todd. We can't, this is not right. You know, here's this kid, he's in crisis, and we're just sitting here, and they just dumped him, essentially. Now there's my lack of compassion. They dumped him. And so we called the hospital where he was before. We called the inpatient unit, asked if they had any beds. They said they had one bed. And so we said, hold it for him, we're on our way. And we grabbed him and we took off. Now that hospital never called to say, hey, your son was here and he's missing.
Where he was, the hospital.
Where he was, waiting in that waiting room. Nobody checked, nobody called his phone, nobody called our phone, nobody called our home, nobody called us. And it is the same medical system, these two hospitals, so they are connected. The docs who work at one work at the other. And nobody checked on this 19-year-old who was suicidal, who was going to jump off a bridge to see, did he jump onto I-5? And I was furious, and still it comes out sometimes, right? About that. How could there be that lack of compassion for this kiddo, you know, who was in a mental health crisis, and you sat him in a huge waiting room all alone, and then you didn't check to see, was he okay, when he didn't come, when you happened to call his name maybe an hour later. But now I know that, you know, they were set up that way, and there's broken systems, and, you know, we don't treat mental illness the same way we do other physical diagnoses who are in crisis. And so we're trying to figure out how to fix that. But it's a lot of work. And I think the first thing is to have compassion for that person who's at the desk, who's limited by what she can do. Have compassion for those EMTs who dropped him off in that waiting room, and have compassion for the providers who are trying to do the best they can, but yet put people at risk.
Absolutely. And it makes so much sense to kind of recognize the anger, I imagine, you know, I would feel in your position, and weighing that with the compassion that, you know, you're practicing. I did want to think a little bit about the doctors, because you did contact the clinicians, the nurses, people that had cared for him afterwards. And I think that's an important piece as well.
I think it was hard, like I said, hard for them. Like, what does this family want to say? Are they going to blame? What are they going to do? Yeah. And then when we stepped into that place of, you know, we want to thank you for caring for him, and, you know, there were things that got in the way and challenges, and we want to be part of fixing the issues, the solutions. You know, we want to be part of that. And just to say, you know, this must be really hard for you. We're a really grieving family, and this is really tough for us. And you cared about our son, and this must be tough for you too. And that was a really interesting conversation and a really interesting moment, because you could see things just turn around, and you could see the humanness in them. Like, the guard just went away, and we were people sitting in a room talking about, you know, this really gifted, beautiful young man who left this world in a really tragic way, and that we could recognize the beauty in other people who may be just like Chad, and figure out ways to be compassionate with them, but be compassionate with the people who care for them. And to say, you know, you're human and you cared for our son. You hear that, I think, a lot in some other diagnoses, like if somebody dies from cancer, I think that that happens quite a bit. People really come back and care for the providers. But I think that in the Department of Psychiatry, at least, it felt like that was sort of shocking for them to have somebody say, wow, you know, you cared about our son. And even though, you know, he died, we care that you have lost a part of him as well. And then being able to say, so how do we help you so that you're okay and that we can work together on fixing the system. That was a really different conversation, and we've actually become friends with some of those people now, and they've been our biggest advocates in trying to move some of this work forward, and have been at the table. And in fact, our daughter is just going to graduate from undergrad and she's going to go to medical school. And one of the psychiatrists has actually taken on a mentorship role for her. And it is this part about, you know, just really, we are humans and we're caring for humans. And we're in this space where, especially right now, it's really tough, you know, with the whole pandemic and people being separate, but we still have to keep that part of relationships and compassion and caring. And when we lead with that, there are amazing things that can happen, and we can change the system to be understanding that the world of psychiatry is not a trial and error. It is a medical field that deserves the same kind of recognition and compassion as all other medical fields do.
Thank you so much for that, Laura. I heard your story a year ago, and I shared with you earlier that that was before I had lost a patient to suicide, and hearing you again, I think what's so telling is the degree of like courage to reach out and create that bridge with caregivers. And I noticed my own reticence to bring that up with you, and notice you're responding to that. And I say that because I think we have a long way to go in recognizing and helping clinicians also talk about this who are psychiatrists in the mental health field. So I really appreciate your willingness to do this work with us.
Yeah, I would, you know, I'll say something that maybe I shouldn't say, but I'll say it anyways, because, you know, why not? One of the things that we hear, not among all, but quite often among emergency medicine is that, you know, lots of times people who say, I didn't go into emergency medicine to treat psych patients. And that's exactly what you went into emergency medicine for, I would argue, is that you went into emergency medicine to treat people in crisis because you think about things in a really critical way, and it's high intensity, and mistakes cause great errors, and it's challenging. It is, I think, a truly challenging part of medicine. And so I would just say to those people who work in emergency medicine, thank you for stepping into that space. And I agree that we have set up systems that don't help with the moving along of patients like we do with medical. You know, people have a heart attack, they don't have to sit in the emergency room for days. They get into a CICU. And we have not enabled that for people who have mental health crisis, but just remember it's crisis. And that I appreciate that it's a tough system that everybody's been put in. There's lots of things to fix. There's lots of things that are going well. There are lots of things that are in the works to make things better. But also just as a real ask for people is to remember these are patients and their crisis is real, and your frustration with the system is real. And we can have both of those things be true and still make it better.
Yeah. As we say in dialectical behavioral therapy, we're doing the best we can and we can do better. Both things are true.
Yeah.
Yeah. We have a couple minutes to wrap up, Laura, and I just wanted you to share just things about Chad that, that were separate from his diagnosis that you'd want people to remember about him.
Yeah, Chad is, I still feel like he's here all the time. I see him around. We talked about that Chad was a quirky kid. He liked to make people laugh, always, even on the night before we lost him. I remember sitting on the couch and him making me laugh. We have triplets, and Chad was 3 when they were born. And I remember Chad lining up the kids in their little high chairs and him acting out stuff to make them laugh. That's who he was. He collected rocks. In fact, I have a big rock collection out on my patio in a glass bowl. And many of those were Chad's. And this will make me a little teary, but when I was washing Chad's pants after we lost him, I swore, not nice words, I really did swear, because his pockets were full of rocks and I put them in the wash machine, not thinking. And so, there's horrible noise was coming out of the wash machine, and I open it up and the wash machine is full of rocks from this kid. And he was kind and he was super smart. And Chad was going to college because he wanted to he went to work for NASA. And that was actually one of the conversations that we had when I was walking around with him when he was inpatient, and we were walking around the grounds when he finally could get out and walk the grounds. And he said, "Mom, do you think that this is going to make it so that I can't work for NASA?" Because that was his dream, was to create a way to tow a ship through space faster than the speed of light using black holes, creating and collapsing black holes. And we actually have a picture that he drew and some physics numbers and stuff that was way beyond, way smarter than me, that he was figuring out. And that's Chad, just this really wonderful, sweet person. When he was inpatient, the attending psychiatrist asked us and Chad if it would be okay if Chad spoke to the medical students, because he wanted them to see another side of mental illness that was actually caring and compassionate and loving, and not just the psychotic that people see. Because even on the inpatient unit, Chad was caring for the other patients, caring about people not looking weird at the woman who was walking up and down the hall screaming and hitting her head, or about, making sure that the guy who was quiet in the room also was present in the room by saying, "Hey, do you have anything to give into this conversation?" That was Chad, even in the middle of his psychosis. He was a wonderful person.
I'm so glad to hear that, because I think when we think about stigma, we reduce whole people, three-dimensional, wonderful people into these little data points. And I think it's really important for us to hear all those parts of him. Thank you.
Yeah. They're not just the people screaming on the corner. They are you and I.
Absolutely.
So there are a few questions from those of us listening, and most of them revolve around what can we do? And it's interesting because everyone refers to the system, and we are the system. I mean, it's doctors and nurses who determine privileges and credentialing in their hospitals. We are the system. We participate in medical and nursing and social work licensures. So it's easy perhaps to say, look what's wrong with the system. But if we look at the people who are on it, they are very much like the people who have been listening. So where do we go from here?
I'll take part of that. And Sophia, I bet you could take part of that too, right? So the very first thing that I'm going to say, and I've used this, I think you guys have heard me say this, but I have used this at work and I use it all the time. And that is, don't wait for the perfect conversation. Don't wait until you have the perfect words. Don't wait. If you see somebody who's struggling, if you see something that's off, If you're just worried, lean into the conversations. You don't have to have perfect words about anything. When we last chat, I had people look at me coming down the hall, look me in the eye, people who I felt like were my friends at work, and turn around and walk the other way. And I know that it was because they didn't know what to say to me. And it's okay. And it doesn't have to be even profound like what happened with me. It can be the small things. If somebody's struggling, just say, hey, I see you. Or you don't always have to ask, are you okay? You can say, I'm really glad to be here with you. Really simple things like that we can do today so that we can have compassion towards each other and move things forward. And then there's bigger systems that, I've already talked about, but Sophia, I'll let you say what can happen.
Well, Laura, I was just going to highlight what you said. I think it's a mistake to imagine, we treat our patients one way and we treat each other another way, that there's one realm for one way and another for compassion. And the reality is, if we want to keep providing the kind of care we idealize, it has to begin with each other, right? And that also goes even further beyond our colleagues, but it has to include our trainees, how we train medical students, how we train nursing students, how we train social workers. It has to be ingrained in us it has to be really fundamental. If we're waiting for it to show up only in the patient's room, I think we're a step too late or a step too removed from it.
And there was another thought that came up, and that was a curiosity, and myself included, about what does mental health first aid look like? I mean, I know what CPR looks like, and everyone does. Teenagers, they know the beat, and we see someone bleeding, put a tourniquet around their leg. But when you talk about this, could you say a little bit more, Laura, about what does mental health emergency first aid look like?
Yeah, so it's a whole program that's been developed, and you can, other people have done some stuff, but this is an evidence-based program through the National Institute of Mental Health. And it has various components. So the very first thing is that you learn about how to ask the question, are you thinking about harming yourself? Are you safe? And are you thinking about harming yourself? And actually practicing asking that question, because you can say you should ask people, it's really uncomfortable to do in the moment. And so they make you practice it in that. You learn about various mental health diagnoses or mental illnesses, including things like depression, how to identify, what's teenage moodiness versus what's depression to be worried about. And then part of that is in asking the question. And then you reassure the person that, you're here, you're listening to them, you listen with empathy, not to fix, but just to listen. You reassure them that they're okay, and then you get them help. Appropriate help, whether that is taking them to the hospital because they need emergent care, whether it is them going and making an appointment with their mental health provider, or whether it is them going to see their PCP, or just in that moment getting them help, and assessing, how to get them help and encouraging them to seek help. And some of it is self-help as well.
Well, I'm saddened to say the hour is coming to an end, and I would like Sophia, if you have a closing word, and Laura, and then we'll wrap it up. So, Sophia, final word.
Oh, so many words. I just want to say thank you again to everyone who participated, and especially to you, Laura, for just being so generous and willing and curious with us. And I appreciate everyone who's helped organize this. And I want everyone to practice some self-compassion.
And so, on behalf of the Schwartz Center, thank you, Sophia. Thank you, Laura. It's been heartfelt and has been a fantastic hour. And thank you for those who listened in our audience and who stayed here with us. I want to thank our national business members for their support, because without their support, we would not be able to have conferences like this. The audience, for those who are here, remember you'll get a summary in the mail. You'll get the information that's needed for you to claim your CME credits and CEU credits. And we will reconvene on Friday, October 23rd, when we will have a panel discussion about caring and advocating for immigrant patients in the current political climate. And the panel will include Altaf Saadi from Massachusetts General Hospital, Chanel Diaz from Montefiore Medical Center and Albert Einstein College of Medicine, and Mark Hughes-Whiskey, who's from Loyola University in Chicago Stritch School of Medicine. So until then, thank you again, Sophia. Thank you, Laura. And thank you, attendees, for being here today. And we look forward to seeing you on Friday.
Thank you.
Take care of each other. Bye-bye.